Welcome! Our topic today is orthostatic hypotension. Orthostatic hypotension, also known as postural hypotension, refers to an atypical drop in blood pressure when a person stands up after having been seated or lying down. When standing, gravity pulls blood down away from the brain, causing arterial pressure to drop. Ordinarily, this drop is transient, lasting only through a few cardiac cycles. If an individual lacks the necessary circulatory reflexes or blood volume upon standing, lesser amounts of blood and oxygen will reach the brain. This is manifested by dizziness or syncope and increases the patient's risk for falls. The baroreceptor reflex normally kicks in to compensate for standing. Baroreceptors located in the vessels of the chest and carotid sense a decrease in blood pressure that will lead to an increase in vasoconstriction and an increase in heart rate to bring blood pressure back up. In the longer term, levels of epinephrine and antidiuretic hormone increase in the blood to also help maintain blood pressure while standing. There are varying causes for orthostatic hypotension. Hypovolemia, or reduced volume in the vascular compartment, is one of them. Blood pressure may be sufficient when a person is sitting or lying down, but when they stand up, they get lightheaded. Some common causes for hypovolemia may include inadequate fluid intake, excessive urination, use of diuretics, excessive sweating, loss of fluids from vomiting or diarrhea, and loss of fluid that occurs from prolonged bed rest. Heart conditions such as heart attack, heart failure, and bradycardia also decrease the cardiac output that is necessary to overcome the pull of blood away from the brain when standing up. Endocrine issues like hypothyroidism or low levels of cortisol, such as with Addison's disease, can lower blood volume and blood pressure, putting a patient at risk for postural hypotension. Diabetes can damage neurons, important in the negative feedback loop for increasing blood pressure when standing. Many medications have the side effect of postural hypotension and increase the risk for patient falls. Meds used for hypertension and angina fall into this category, including alpha blockers, nitrates, ACE inhibitors, ARBs, calcium channel blockers, and beta blockers. Other drugs that may cause orthostatic hypotension includes drugs used for erectile dysfunction, like sildenafil, sedative or anti-anxiety drugs like benzodiazepines, hypnotic drugs like zolpidem or diphenhydramine, muscle relaxers such as cyclobenzaprine, tricyclic antidepressants or TCAs used for depression or nerve pain, dopaminergic agents used for Parkinson's disease such as levodopa, both atypical and typical antipsychotics, anticholinergics like oxybutynin, opiates like morphine, and cardiac glycoside digoxin used for heart failure or atrial fibrillation. Alcohol, the most commonly used CNS depressant, also increases the risk for orthostatic hypotension since it causes vasodilation. Orthostatic hypotension becomes more of a problem with increasing age. This is due to decreased activity of compensatory mechanisms like the baroreceptor reflex. Elderly persons also have reduced blood volume and reduced skeletal pump function, which further complicates the problem. After age 70, patients are more likely to experience postural hypotension due to the aging process, and this is the most often systolic dysfunction, which causes a decrease in blood flow to the brain. Elderly patients also are more prone to be taking antihypertensive medications or diuretics, which further compounds the problem. In addition to dizziness, patients may experience weakness and ataxia, which may include abnormalities in gait and speech. It's important to treat and prevent orthostatic hypotension, especially in the elderly, because fluctuations in blood pressure to the brain increases the risk for stroke and complications from cardiovascular disease, like angina, heart failure, and arrhythmias. Having healthy skeletal muscle pumps helps blood return to the heart to increase preload, to help prevent orthostatic hypotension. Being immobile and confined to a bed brings about changes that beget postural hypotension, and mobile patients have reduced plasma volume and decreased muscle tone in skeletal muscle pumps, all which decrease blood returning to the heart to decrease preload. The decrease in plasma volume is observed after only 3 days of being on bed rest. The decrease in activity of skeletal muscle pumps usually takes about 2 weeks of being on bed rest. Peripheral neuropathy associated with diabetes mellitus, spinal cord injury, and cerebral vascular accidents, such as a stroke, can all impair autonomic nervous system reflexes necessary to maintain blood pressure upon standing. In neurodegenerative conditions such as Lewy body dementia, amyloidosis, Parkinson's disease, and Shy-Drager syndrome, autonomic nervous system neurons may fail, bringing about orthostatic hypotension. To diagnose orthostatic hypotension, it is important to obtain a thorough medical history. This includes history of syncope and falls, medication history, and history of medical conditions. Blood pressure is measured while the patient is supine, sitting, and standing. Symptoms while in these different positions will be noted. Diagnostic criteria for orthostatic hypotension is a decrease in systolic pressure of at least 20 millimeters of mercury, or a decrease in diastolic pressure of at least 10 millimeters of mercury during the first 3 minutes of standing. A tilt table can be used to safely move the patient from recumbent to standing positions and vice versa. Blood testing for hypoglycemia and anemia may be performed. An EKG or echocardiogram may be performed to test for cardiac arrhythmias and for structural changes in the heart, such as from valvular disease. These tests may be performed while walking on a treadmill to determine heart function under stress. Treatment focuses on determining the underlying cause. For example, it may involve changing medications or taking vitamin supplements like iron or vitamin B12 if the patient is anemic. Important lifestyle modifications for patients include standing up slowly to allow negative feedback mechanisms to kick in when going from a supine position to standing. It may also be helpful to sit on the edge of the bed for a moment before standing up, and while doing so, contracting the calf muscles to increase blood return to the heart. If symptoms come on while standing, contract thigh muscles or rise up on your toes to contract the calf muscles. If you need to bend down to pick something up, don't bend down at the waist. Instead, squat by bending your knees. Using pillows to elevate the head while sleeping will decrease the chance of hypotension when you get up. It's important to avoid things or conditions that can cause too much vasodilation, such as drinking alcohol, intense exercise in hot environments, or saunas. Be aware of what may lead to dehydration, including diaphoresis, lack of fluid intake, and vomiting or diarrhea. Support hose or abdominal support clothing can be used to keep blood from pooling in the legs and abdomen. These supporting garments should be taken off when lying down. It may be necessary for those that have a drop in blood pressure after meals to eat smaller meals. Also, measures may be taken to increase vascular volume, such as increasing salt in the diet, but should be done in moderation and with physician approval. Several medications may be used to treat orthostatic hypotension when lifestyle modifications are not possible or inadequate. Fludrocortisone or midodrine are used most often. Fludrocortisone is a mineralocorticoid that acts like aldosterone to help the body retain salt and water, thus increasing blood pressure. Midodrine is an alpha-1 agonist that causes vasoconstriction in arteries and veins. Droxidopa may be used to treat orthostatic hypotension due to certain neurodegenerative conditions, such as Parkinson's disease. Droxidopa acts as a prodrug for norepinephrine, and unlike norepinephrine, it can cross the blood-brain barrier. Less commonly used drugs include the following. Indomethacin is an NSAID that reduces vasodilation caused by prostaglandins. Phenylephrine and clonidine are both sympathomimetic drugs. Phenylephrine is an alpha-1 agonist, and clonidine increases sympathetic output to increase vascular resistance. Propranolol is a non-selective beta blocker, and its action on blocking beta-2 receptors in the vessels causes vasoconstriction. Pyridostigmine is an anticholinesterase medication that increases levels of acetylcholine in the ganglions of the baroreceptor pathway, making the pathway more active to resist orthostatic hypotension without worsening supine hypertension. Octreotide is a somatostatin analog that causes some vasoconstriction. Desmopressin nasal spray is a synthetic form of vasopressin that increases water retention and causes vasoconstriction. To summarize, orthostatic hypotension is the low blood pressure resulting from inadequate blood in the brain that can bring about syncope. There are many potential causes, including conditions that cause hypovolemia, heart conditions, hypothyroidism, Addison's disease, and diabetes mellitus. It's also the side effect of many medications, especially those used for hypertension and angina. Advancing age, immobilization, and nervous system complications also increase the risk. Treatment measures include addressing the underlying cause, making lifestyle modifications, and in some cases, using medications. Thanks for watching.